So today in this video we're going to talk about the CNS pharmacology, and we're going to do this right here in one piece, all of this. So the table of contents for this video are going to be a general, very brief introduction, and then we're going to go to sedatives and hypnotics. Then we're going to go to anti-seizure drugs, general anesthetics, local anesthetics, skeletal muscle relaxants, Parkinsonism drugs, antipsychotics, antidepressants, and opioids. And for drugs of abuse and alcohol, we're going to do a separate video. So I know this is going to be a long session, but let's do this. Okay. So the really first thing that we're going to do is the introduction is the synapse. We are going to learn what actually goes on in a synapse. So for a synapse, this is the presynaptic neuron and this is the postsynaptic neuron. And right here, what generally we need to see is that we know that in the CNS, of course, it's made up of all these neurons and glial cells that basically support the neurons. The thing that we need to know is that how does these neurons communicate with each other? So that communication is basically called as a synapse. So these are the interconnections that this is the way that the neurons talk to each other. So that's we're gonna see right here how that communication, that talking is done. So in a presynaptic neuron, the first thing that has to happen is that there should be some kind of precursor molecule, let's say amino acid, right? And this amino acid is converted into a neurotransmitter. And this neurotransmitter is then packaged into a vesicle, like that. So this is a vesicle containing a lot of neurotransmitters, molecules. So this is a vesicle. Now what happens is that when an action potential arrives, so this is an action potential that arrives through the presynaptic neuron, the membrane is going to get depolarized. The depolarization of the membrane is going to happen, and that is going to open calcium channels. So these are calcium channels. They open and it is going to get an influx of calcium. And that influx of calcium causes this vesicle to fuse here through the membrane, and that's how the neurotransmitter is released into this area. This area right here, this is called as synaptic cleft. It's really important concepts that you need to know, that you must know at this point, you must know that this point is that synaptic cleft, whatever there is the neurotransmitter, if it stays in the synaptic cleft, this means that it is going to be communication friendly. It is going to communicate to the next post neuron. Okay, so we need more of this neurotransmitter here so that we can generate an action potential in this neuron. Okay, so that's important. That's why we need the neurotransmitter to concentrate in this area. Okay, and so what's next is that this neurotransmitter is going to stimulate a receptor on postsynaptic membrane, and that is going to cause depolarization via sodium channel opening in this neuron. So now this neuron is going to get depolarized. So that's how one neuron to another neuron, a synapse, is formed, when one action potential from one neuron is getting to the second neuron. Now it's that simple actually, but there are few more things that you need to know, and then you're set for learning its pharmacology. Okay, so for that I'm gonna change the color. Right here on the presynaptic membrane, there are some other receptors that are important is one are reuptake one. So this is a reuptake receptor. What this is going to do is it is going to reuptake this neurotransmitter back to the presynaptic neuron. That's one thing. Another thing, on the presynaptic membrane, there are other receptors like these. These receptors are autoreceptors, and these are going to inhibit the presynaptic receptor. You'll see examples when I talk further in this video. Okay, one more thing. On the postsynaptic neuron, there is another receptor right here, which is basically a chloride channel receptor. It's called a GABA receptor. We're going to talk about that. This is an inhibitory receptor. Okay, so that is a very basic thing that you need to know to really master the concepts of CNS or neuropharmacology. Now we're gonna briefly look at the types of all of these neurotransmitters, basically the messengers here. So there are some biogenic amines, for example ACH, acetylcholine. Then we have amino acids. These could be glutamate, for example. That's a very good excitatory one. And then we have monoamines. For monoamines, we have, GABA, sorry, not GABA, dopamine and serotonin. GABA is an amino acid. Okay, dopamine and serotonin, etc. So they're just like rough types. Another thing that you need to know when we're going to talk about antipsychotics and antidepressants, but it's better to just do this right now, is to know certain pathways. So we're going to briefly go through them. The first one is the dopaminergic pathways. Now there are essentially 4 pathways already in front of you. So I'm just going to tell you what these pathways do. So the nigrostriatal pathway, this basically is the pathway that is involved in Parkinson's disease. So this is going to be for movement. This is going to be related to the movement. Okay, so it goes from the substantia nigra to the basal ganglia. Okay, so these are all the dorsal striatum and putamen. They're part of the basal ganglia. Then we have the tubuloinfundibular pathway. This tubuloinfundibular pathway, it goes from right here, from the hypothalamus to the pituitary gland, and this is responsible for prolactin release. Okay, so this is actually an inhibitor of prolactin release. So it inhibits dopamine, is actually PIH. It is dopamine is equals to PIH, and it inhibits the release of prolactin. And then we have the mesolimbic pathway. Mesolimbic pathway is related to emotions, and it goes from the tegmentum of the midbrain to the, so there is the tegmentum of the midbrain, or the ventral tegmental area of the midbrain, to the cortex. Then we have the mesocortical pathway, and this is the pathway if this is damaged, or there is like chemical imbalance in this pathway, we're gonna have psychosis. So this is from the ventral tegmental area to the cortex. Okay, so both are going to the cortex. Mesolimbic is from the emotional to the limbic system, and mesocortical is from the ventral tegmental area to the cortex. Okay, then we have serotonergic pathway. It's the most easiest. We don't have to worry much about it. It's just raphe nuclei in the brainstem, and some of them are going to your cerebellum, while others are going to your cortex, as well as your thalamus, and as well as your limbic system. So yeah, that's that. Okay, now let's do sedatives and hypnotics. Okay, so now for sedatives and hypnotics, we are gonna first talk about the two major classes of sedatives and hypnotics, and then we're gonna talk about some others as well. So the first thing is that what is sedation and what is hypnosis? Sedation is something that makes you sleepy, and hypnotics is something that will put you to sleep. I hope this simple, silly words will help you understand it better. So this is really gonna make you sleep, okay? This is the real deal, and this is just gonna make you drowsy and dizzy and all that. Both work, actually. Both will put you to sleep. Once some just work better than the others, right? Okay, so here we're gonna talk about barbiturates. We're also going to talk about benzodiazepines, non-benzodiazepines, and then others. The others are, number one is orexin antagonists. I'll tell you what all of these in a while. And the other is the melatonin or MT. Let's just write MT agonists, and 5-HT agonists. Okay, now we are going to get into the details of barbiturates first. So for barbiturates, you need to know for both of these benzodiazepines and barbiturates, there is one mnemonic that you need to know, is that you have to get in the habit of saying barbiturates as barbiturates. Okay, so from here you will know that this thing is going to cause increased duration of chloride channels, okay? And benzodiazepines, by the rules of exclusion, it is going to increase the frequency of chloride channels. Now the thing is, what are chloride channels? So in order to know that, we are going to do a little thing here. The thing is that GABA receptor that I talked about above, it's actually pentameric receptor. So pentameric means it has 5 subunits. So I'm gonna try to draw it out. 2, 3, 4, and 5. So these are the 5 subunits. And of course there are 2 alphas, 2 gammas, and 1 beta. And one is a benzodiazepine receptor site, one is a barbiturate receptor site, okay, and one is of GABA, and the others are, these are the important sites. So the sites on the receptor are different, right? And so when a benzodiazepine will attach to the alpha subunit, it is going to increase the frequency of this channel, because this channel, when any one of this is going to bind to it, it is going to increase chloride. So chloride is basically, it's a channel protein. That's why chloride can easily pass through it. Okay, so that is the simple thing that you need to know, the mechanism of action. It's just that simple, guys. It's a very simple mechanism of action. Next thing are some of the names that you need to remember for this. So really easily, just, I hope these are not very difficult names for barbiturates. I remember it: pheno, pento, thio, seco. All of these, and then barbitol. So phenobarbital, pentobarbital, thiobarbital, and secobarbital. And for benzodiazepines, the most important one is diazepam. And then there is an mnemonic called as ATOM. So A for alprazolam, D for triazolam, O for oxazepam, and M for midazolam. My dear, these all are what? They are short acting. So you need to remember it like that. And another one is LOT. This is lorazepam, oxazepam, and temazepam. They have a high, they can be used in liver disease patients because they have very, very, very less first pass effect. Okay, so if you know your basic pharmacokinetics, what that means. All right, now what other things that you need to know for these are the clinical uses. Now you're gonna see barbiturates and benzodiazepines a lot in the following video because they are used a lot actually in different things. Some of them are anxiety, seizures, insomnia, and anesthesia. Some of the side effects that you need to know are very important, so we're gonna actually spend some time looking at that. The first one is barbiturates. So the single one thing is that it is going to cause respiratory depression. Second is cardiovascular depression. Okay, and then of course CNS depression. And it has a very, very high dependency. And because of its CNS depression, never give it with alcohol because that is just going to make it worse. And it is, my dear, it's a B450 inducer. So you need to beware when you are giving it to anyone. So this is basically contraindicated in porphyrias as well. And benzodiazepines, they are also, again, the adverse effects are dependence. And this causes CNS depression as well. And, but, you know, this do have a cardiovascular and a respiratory depression risk, but that is definitely lesser than barbiturates. And lastly, it can also cause coma. But a good thing for benzodiazepines is that for benzodiazepines we have flumazenil, important, very, very much. This is an antagonist at BZ1 receptor site on GABA. So if you have an overdose of benzodiazepines, you can give flumazenil. Right. Now that's that. We're gonna now move on towards benzodiazepines. I'm gonna erase extra things. And now we're gonna talk about benzodiazepines. So non-benzodiazepines, these include zolpidem, zaleplon, and zopiclone. These all act via the BZ subtype again, So these are also acting via the receptor subtype. So basically, it is the same receptor site, but its chemistry is different. It's non-benzodiazepine. The chemistry is different altogether. The things to note about this is they are short acting. They have a short duration of action, and that is because it is it has a rapid metabolism. And the next one is that they are better and preferred over benzodiazepines because they have a decreased dependency risk and decreased sleep disturbances. They just do the work and they're good to go. So what do you use them for? You use them for putting people to sleep. It's a hypnotic, okay? Some of the adverse effects for this is you can have headaches. Why not? Yeah. And ataxia. Confusion can be there. And very rarely, it can also cause psychomotor depression. Like that. Okay, next we're going to talk about orexins. So for orexins, we have the prototype that is called as suvorexant. So here you go, orexin, that's how you remember it. So it's an orexin antagonist, and this causes CNS depression and somnolence, but you don't give it in patients with narcolepsy, okay? The next one is ramelteon, that is the MT antagonist. Ramelteon, so melatonin. So MT is a melatonin receptor where? In the suprachiasmatic nucleus. Suprachiasmatic, the suprachiasmatic nucleus, it is near the supraoptic nuclei in the hypothalamus, and it controls your circadian rhythm. That's how it puts you to sleep, because it agonizes that part. The next one is 5-HT agonists. So these are basically triptans, and you call them, the example is sumatriptan. And sumatriptan is used in migraines, so you need to know that this is used in migraines, okay? And also, why do you use it in migraines? Is because it is going to inhibit the trigeminal nerve. Plus it releases it causes vasoconstriction because it delays the release of, or stops the release of, vasoactive peptide. So that's how you use it for headaches, cluster headaches, and migraines. And that's that for sedatives and hypnotics. Okay, so for anti-seizure drugs, first we need to know what is epilepsy and seizure. So first is seizure, and the second is epilepsy. So seizure is basically abnormal firing of neuronal circuits, and epilepsy is repeated episodes of seizures. Mostly if there are 2 or 3 episodes of seizures in over a course of 6 months, you start the patient on anti-epileptics. All right. Now, before we really jump into the pharmacology, first, to really understand the mechanism, we need to draw out our pretty little synapse and the neurons architecture. Okay, so what is happening right here is I'm going to show you a very simple synapse. So this is the synapse right here. So this is the synaptic cleft right here. Okay, so first what happens? The very first thing is through the presynaptic excitatory neuron, we're gonna receive ourselves a little good action potential. And how does that action potential reaches? Is by sodium influx, right? This is gonna cause depolarization, and this depolarization is going to cause glutamate, which is of course, this is an excitatory, so we're gonna have a glutamate with us because that's an excitatory neurotransmitter, and we're gonna have a glutamate release, and that glutamate is released to the synaptic cleft, and on the postsynaptic neuron we have two receptors. We're gonna make it different. One is the AMPA and the other is the NMDA receptor. Okay, and they're going to AMP cause influx of sodium when it is attached by glutamate, and the NMDA is causes the influx of calcium. Okay, and that's how your postsynaptic neuron is going to get depolarized, and that is an action potential. But also there is a inhibitory neuron lurking by, and this inhibitory neuron, this is very sneaky, is because this has another little sneaky thing, is that this releases GABA through the same way we saw before. Action potential will arrive and it will cause GABA release, and this GABA is going to attach to the GABA receptors right here. So this is going to go here. This is a GABA A receptor. Okay, so this is a GABA A receptor, and this is going to cause influx of chloride, and that is going to cause repolarization. So this is going to give negative feedback to the depolarization, because it's going to cause repolarization. But again, this looks simple, but there are two more things and then you're good to go. The first channel right here is the calcium channel, and because when this voltage calcium channel causes the influx of calcium, that is when the vesicle release occurs. But there is another thing, that vesicle which has glutamate in it, that vesicle has another little receptor attached to it. That is the vesicle receptor, that is called SV2A receptor. Okay, and there is another thing, there is another receptor right here on the inhibitory neuron that is called as a GABA reuptake receptor. Right, so when I have all of these receptors and I really understand this whole picture really well, you know, because this reuptake receptor, what's going to do, it's going to reuptake all of this GABA that is in this particular synaptic cleft, right? It's just going to take it up. Now what? We are going to apply pharmacology here. Now we're going to do the classification of anti-seizure drugs. Now I'm going to do all of this in pretty pink, is to make you understand what we really need. So what actually happens in epilepsy is that there is a lot of excitation, you know, and there is no inhibition. So we need to do two things to treat epilepsy, because there is lack of inhibition and there is just too much excitation. We can do two things. The first thing is that we need to decrease excitation and we need to increase inhibition. Now, ladies and gents, how are you going to do it? Look at here. in this diagram, I'm going to change color, make it a pretty, let's see, green color. How can we first decrease excitation? We can decrease excitation if this action potential really doesn't come, right? How do we make it stop? We are just going to inhibit this sodium channel. Okay, we can do that. The other thing, what else can we do? We can prevent this glutamic vesicle release, and we can do that by two types. One, the more conventional way, we can stop this calcium baby, right? The next thing, what we can do, we can inhibit that SV2A receptor, right? What else can we do? We can block right here. We can give GABA. Now we need to do, okay, we've done excitation. We need to do inhibition. Now we have to increase inhibition. How do you increase inhibition? You're going to antagonize GABA A. You're going to antagonize GABA reuptake receptor. So agonize GABA A receptor and antagonize GABA reuptake receptor. So we have more GABA in the synaptic cleft. So if we have less glutamate, in the synaptic cleft and more GABA in this particular synaptic cleft, we are not going to stimulate this postsynaptic neuron, and we are done. There will be no seizure. That is basically the concept that we want to do right here. Okay, that is what is our goal. Now let's see what are the drugs that we give. Okay, so for this, first we're gonna do the classes that increase GABA. So the classes that increase GABA is, well, there's a mnemonic for that it would be great that you would remember it easily, is baby goes to Venus. Okay, so basically the first is GABA channel agonists. Another one is GABA releasers that causes increased release of GABA. The other is GABA reuptake inhibitor, so that's called GAT1 inhibitors that inhibit the reuptake of GABA, and transaminase 1 inhibitors. So let me first go back and tell you where are these located. This is the GAT1 gate, GAT1. So here when GABA is brought back into the inhibitory neuron, here it is transformed back to succinyl semialdehyde SSA by GABA transaminase. So we literally give inhibitors to this channel as well. So those are called as transaminase inhibitors. I is for inhibitor. So what is baby goes to Venus? Baby goes to Venus are the drugs. So GABA channel agonists are benzodiazepines. So 1B right here is for benzodiazepines, and then barbiturates. This B is for barbiturates. And GABA releasers is gabapentine. This is for the G. And for GAT1 inhibitors, it's tiagabine, and this is for 2. And transaminase inhibitors are vigabatrin and valproate. That is for Venus. Venus is for vigabatrin and valproate. So this makes it pretty easy to memorize all of this. We're gonna do little details of all of these, but first let's go on the other, do the rest of the classification. And we're gonna come back to individual drugs later. Next is to decrease glutamate. We are going to give NMDA antagonist, NMDA antagonists, and AMPA antagonists. And the examples to these are NMDA one is phalbamate, and AMP antagonist is perampanel. And perampanel is used for focal seizures. I'm also going to just talk about that in a bit. Sodium blockers. Sodium blockers, the way to remember sodium blockers is Carl, Frank, and Larry purchased a TV. So right here, Carl is carbamazepine, Frank is fosphenytoin, Larry is lamotrigine or lamotrigine, P is phenytoin, and V is valproate or valproic acid. Then we have calcium blockers. Calcium blockers, you have to remember it as CAVE. So calcium blockers are VE. So V for valproate and E for ethosuximide. Ethosuximide. And SV2A blocker is just one, that is levetiracetam. Okay, and first we're also going to do classification based on the treatment of seizures. Let's go through that real quick as well. The first one is general tonic-clonic seizures. These are, you can remember it by VLL player. Remember VLC player? I just transformed it to VLL player. V for valproate, L for lamotrigine, and then another L for levetiracetam, and P for phenobarbital. And then myoclonic seizures, remember it by VLC, V for valproate, lamotrigine, and carbamazepine. Absence seizures are very easy, again remember by CAVE. So they are valproate or valproic acid and ethosuximide. And partial focal, you can remember, they're actually a big list, so I did not make any mnemonics. So they are carbamazepine, gabapentine, levetiracetam, phenytoin, and valproate, vigabatrin, and phenobarbital. Okay, and another thing right here is status epilepticus. For status epilepticus, one is benzodiazepines. Let me just write the short form of this. Benzodiazepines, BZDs, and we use phenobarbital, and phenytoin. Now let's talk a bit in detail about some important drugs. Again, we know the mechanism of action right now, but there are some drugs that have overlapping mechanisms of action, like one would have 2 mechanisms of action, 3, and like that. So I would like to go over that. The first drug is benzodiazepine. Let's talk about that. Benzodiazepines has one action only, that is GABA. It acts on GABA receptors. The thing that you need to know, the important thing that you need to do is that it can be used for eclampsia seizures. Eclampsia seizures. But for eclampsia seizures, what are the first line? The first line is Mg SO4, and then you're going to use benzodiazepines. Then we have carbamazepine. For carbamazepine, you can do, the really important thing about this is that it is first line for trigeminal neuralgia. That is really important. You need to know this. Carbamazepine is first line for trigeminal neuralgia. It will really come on a lot. These side effects are important. The side effects of carbamazepine include Stevens-Johnson syndrome and blood cells dyscrasias like agranulocytosis. These are the two most important, and of course there is teratogenicity associated. The next is ethosuximide. For ethosuximide, the important thing to know is that this affects thalamic calcium channels. So that is why they're used in absence seizures. And the big adverse effect is Stevens-Johnson syndrome. And of course, it's used for absence seizures. Then we have gabapentin. Gabapentin is used for both calcium channels and GABA analog. So it does both. It blocks calcium channels and plus activates GABA. And yeah, that's that. Then we have lamotrigine. Let me write it here. Lamotrigine. Lamotrigine causes Stevens-Johnson syndrome. And it has two functions: sodium channels, sodium block, plus it also does is that it inhibits the release of glutamate. Then we have levetiracetam. Levetiracetam, it has also two functions. First, it blocks sp2a, and it also blocks calcium channels. Then we have phenobarbital. Phenobarbital is first line in neonates, and we have already done barbiturate's side effects. Then we have phenytoin. Phenytoin, the most important thing is that it is highly toxic. So to know this, we are gonna form a mnemonic, that is p-phenytoin. P for P450 induction. Then we have pseudo lymphoma, hirsutism, and E is for enlarged gums, N is for nystagmus, yellow-brown skin, T is for teratogenicity. This is called as fetal hydantoin syndrome. O is for osteopenia. I is for inhibited folate absorption, and N is for neuropathy. Really important to know, the takeaways are teratogenicity. It is absolutely contraindicated in pregnancy. Next is topiramate. Topiramate. And it has two actions again. One is sodium channel blockage, and then of course GABA. It increases GABA. And lastly, we have valproic acid. And valproic acid also has two functions. First is sodium block and increases GABA. And of course, we know how does it do that. It inhibits the GABA transaminase. And important side effects include teratogenicity again. It is teratogenic and it causes liver damage. Vigabatrin. Vigabatrin causes a vision loss. That is important to know. That causes vision loss. It's a black box warning. Okay, it causes permanent vision loss. Another one is a black box warning is the lamotrigine. This is also a black box warning because it's highly toxic. Black box warning. Black box warnings are basically, it's written on the medicine box that it's a high alert and it's really, really toxic. And here our anti-seizure drugs are done. Okay, next is general anesthetics. So in general anesthetics, first you need to make it clear what is anesthesia and what is analgesia. Anesthesia is loss of senses, and analgesia is loss of pain. Analgesia is a subset of anesthesia. They are not the same. In anesthesia, you not only feel pain, but also you are also unable to feel anything else. So that is that. Okay, now we are gonna do, there are four stages of anesthesia. First is the induction phase. Then we have maintenance phase. And then we have surgical anesthesia. And then we have medullary depression. So it is at this area, this stage, where surgeries are usually performed. And when it goes to medullary depression, then the anesthesia becomes irreversible. Okay, so to start with classification, there are some things that need to be considered before we move forward. Is that first, the thing that must be understood is that CNS drugs must be lipid soluble, and this solubility will help them cross the blood-brain barrier. And some important concepts right here, I'm going to write them here. One is of blood to gas ratio. When we have a decreased blood to gas ratio, this means that drug is going to induce rapidly if this is decreased. So that's the basic concept, that what is the ratio of the anesthetic agent from blood to gas. And then we have minimum alveolar concentration, that is MAC. And this is basically the definition of MAC is the minimum alveolar concentration of any anesthetic that is required to prevent 50% of the subjects from moving in response to a noxious stimulus. So 1 by MAC is equal to potency. So the lower the minimum alveolar concentration of an anesthetic agent is, the lower the concentration required to move into the blood is basically the MAC. That is how much potent a drug is. So lower the MAC, the more potent the drug is. Now, for example, we have nitrous oxide, that is basically a gas. Nitrous oxide, this has a lower blood gas ratio or blood and lipid solubility, but it has a very low lipid solubility as well. Okay, so low lipid solubility and low blood gas ratio or blood solubility, let's just say. When both of this is low, this is going to induce fastly, so fast induction, but it has low potency because the minimum alveolar concentration required is very high. But it's opposite for halothane. For halothane, which is halogenated. For halothane, it is more lipid soluble and it is more blood soluble. So it has high potency and slower induction. Okay, so what others are the halogenated? Halothane. Then we have the other examples. Two halogenated ones are isoflurane, desflurane, and sevoflurane. And unhalogenated ones are others, like ether, and for gases, N2O. For all of this, the mechanism is unknown. How they work, we really don't know. But what are the effects? The major effects are cardiovascular depression, CVD depression, plus respiratory depression, plus increased cerebral blood flow, and increased intracranial pressure. Some of the important side effects, for example, of halothane, the big one is hepatotoxicity. For methoxyflurane, we have nephrotoxicity. And others like enflurane is epileptogenic, and etc. Another important thing to consider is malignant hyperthermia. Malignant hyperthermia is a triad of symptoms: increased temperature, increased muscle contractions, and increased carbon dioxide. So what actually happens that in induction of anesthetics or succinylcholine, the severe muscular contractions occur with high temperature, and that is mostly life-threatening. And why does this occur? This occurs because there is a mutation in ryanodine receptors. So what do you do is you give an antagonist that is called as dantrolene. Very, very high yield. You need to know this. It's important. Dantrolene is given as a ryanodine receptor antagonist to prevent malignant hyperthermia. Next, we have the intravenous general anesthetics. For intravenous general anesthetics, first are the induction, ones that cause induction. These include propofol, pentyl, and etomidate. And for slow inducing, we have ketamine and midazolam, yep, that's enough. You can also write opioids in here, but let's just stick to above because they are more used. So propofol is basically a GABA analog, so it is a GABA agonist. So this is a GABA agonist. Okay, it is going to increase GABA, and you use it for induction. It is a rapid anesthesia, and it's used for short procedures. Then is thiopental, that is basically barbiturate. Again, it is used for induction and for very short surgical procedures. Then we have etomidate. Again, etomidate is used for induction. Then we have slow acting, that is ketamine. Ketamine is a NMDA agonist. And for ketamine, the important one is dissociative anesthesia. The dissociative anesthesia is such that the patients are lying on the operating table and they feel like that their soul has removed from their body, and then they levitate above the bed and watching from that they are lying on the operating table. So that's like dissociative anesthesia. It's very cool that happens. And again, we use ketamine. Another important thing for ketamine is that it is a sympathomimetic. So of course, it is also filled with a lot of side effects, and it is of course drug abuse as well, but we're going to talk about that later. For ketamine, another thing is emergence, delirium, or reaction. In emergence delirium, what happens that whenever the patient wakes up from the anesthesia, they are very either aggressive, disoriented, or they're hallucinating, etc. And then we have midazolam, that is a benzodiazepine. Again, it is a procedural sedation, mostly procedural sedation, like in endoscopy, you would give midazolam. And the side effects are the same for benzodiazepines. And that is enough for general anesthetics. Let's do local anesthetics. Then we have local anesthetics. The local anesthetics are of two types. They are amides and esters. So amides are with a double I. Okay, so like lidocaine has two I's in it, and then we have mepivacaine, bupivacaine, ropivacaine. Two I's, right? And for esters, they are like cocaine, procaine, and benzocaine. These are all esters. If your patient is allergic to esters, you are going to give them amides. Okay, what is their mechanism of action? Their mechanism of action is that they are sodium channel blockers. They are tertiary amines. Okay, and they can be they're basically amines. But if they are tertiary amines, they are going to pass uncharged through the channel, and then they're going to become charged and then bind to the ion channels. Okay, so if they're uncharged, they're going to cross the lipid soluble membrane, and then they're going to become charged, and then they're going to block the sodium channels. If you are giving anesthesia into a infected tissue, the infected tissue is mostly acidic, so alkaline anesthetics are not going to penetrate easily because they're charged. So you need to more and more anesthetic. Another important thing for these anesthetics are the order of loss, okay, of anesthetic. For the first one, you're going to first lose the sensation of pain, then you're going to lose the sensation of temperature, then you're going to lose a sensation of touch, and then you're going to lose a sensation of pressure. Important adverse effects are cardiotoxicity, hypertension, hypotension, arrhythmias with cocaine, and methemoglobinemia with benzocaine and prilocaine. And that is it for local anesthesia, nothing more, nothing less. And we are halfway through the video, and it's 1 hour already. Okay, now we are gonna do second skeletal muscle relaxants. The skeletal muscle relaxants are divided into centrally acting and peripherally acting. Centrally acting, these act on the spinal cord and supraspinal regions, and peripherally acting are in the peripheral areas, okay, in the lower motor neurons more specifically. Okay, so first we're gonna do the centrally acting ones. So right here we have this little diagram. We're gonna do this. This right here is an upper motor neuron, this is a lower motor neuron, and this is an inhibitory neuron. Okay, and in here we have in the upper motor neuron we have the GABA B receptors, and on the lower motor neuron we have the GABA B receptors and GABA A receptors. On upper motor neuron we also have an alpha 1 autoreceptor, alpha 2 autoreceptor in the presynaptic neuron. Now here we're gonna have some drugs that are gonna come and act on this. The first one is the alpha 2, and the drug that acts on alpha 2 is diazenidine, and this potentiates alpha 2 receptor, and this alpha 2 receptor is of course going to decrease the receptors or the neurotransmitter release. Okay, that's alpha 2. Okay, next is GABA B antagonist. So baclofen is it is going to potentiate GABA B receptors, so this is also going to stimulate GABA B receptors, and of course that is going to inhibit the neurons, the lower motor neuron. And GABA A receptor, it is inhibited by benzodiazepines. It is stimulated by benzodiazepine. It never inhibits, it always stimulates. Okay, so some things to know. The baclofen, it always acts on the back. So baclofen back, so acts on the back. Okay, you're gonna give it on the back. What are the clinical uses when you have muscle spasticity or multiple sclerosis? And for benzodiazepine we have the cyclobenzaprine, and this mainly acts on CNS. Okay, mainly at the brainstem. Okay, and it is also centrally acting, so C4 CNS or CNS, and it is structurally related to TCAs. Anyways, next we have diazenidine. Diazenidine is alpha 2 agonist, and this is used in muscle spasticity, multiple sclerosis, ALS, and cerebral palsy. Okay, now we are gonna do peripherally acting ones. In peripherally acting we have direct acting, and then we have NMDA blockers. So for the direct acting we have the example of dantrolene. Remember, dantrolene is a ryanodine receptor antagonist, so it is going to decrease calcium release from sarcoplasmic reticulum, and definitely it is given to decrease muscle spasticity. Okay, next we have the NMDA blockers. The two examples of energy blockers are depolarizing and non-depolarizing. So let's get into this. The prototype of depolarizing one is succinylcholine. I want you guys to remember that depolarization means activation. So this might seem paradoxical at first, but I'm going to explain it to you how this is not paradoxical at all. So look at this. This is our postsynaptic nerve terminal, and this is our ACH receptor. Succinylcholine is an analog of acetylcholine. So this is going to come and bind here, and this is going to generate an action potential in the muscle, and that is going to cause activation of the muscle, right? That's true. That is how a depolarizing one occurs. Now you see that this succinylcholine has a longer duration for remaining attached to this ACH receptor. Normally what happens is, this is the ACH receptor and this is ACH. This is going to come bind, generate an action potential, get detached, another ACH is going to come bind and do. So this is on and off kind of system. But in case of succinylcholine, it is going to stay and remain attached. Like, for example, when you are at a party and your friends are hugging each other, so it's like one hug at a time. But you know, when there's some kind of a friend who hugs you for such a long time that you just like, please just leave me alone, right? The same thing happens here, okay? That's the same concept. The receptor gets tired of the succinylcholine and there's like, just stop it, okay? So that nerve terminal is then, first it remains depolarized. It remains depolarized for such a long time that it gets tired and it relaxes. The muscle relaxes. So due to sustained stimulus by succinylcholine, the muscle stops getting stimulus from the succinylcholine and it just relaxes. It doesn't remain contracted anymore, and that is the function of that is the mechanism of action of depolarizing the depolarizing skeletal muscle relaxants. Now the thing to notice is that you see that of course this mechanism of action is really fishy. So we're gonna have phases right here. So there's two phases. The one is the depolarization phase and the other is desensitization or repolarization phase. Now of course you all know this, and I already told you about this, that this kind of thing is not going to remain attached to it. First it's going to remain depolarized, but then there will be a time when this succinylcholine cannot work on this postsynaptic terminal, and the postsynaptic terminal is going to get desensitized. That happens in phase 2. Okay, so that is a good concept there. Now it doesn't stop there. We need to know some more things than this. There is a concept, you know, like I also told you before about malignant hyperthermia that was caused by succinylcholine. There is another thing that happens because of succinylcholine. Now you see that because succinylcholine is a depolarizer, it is causing contraction in the muscle and then causes relaxation. That is of course going to cause fasciculations, muscle fasciculations. It is going to cause that. And in order to prevent this phenomena, what we do is that we administer small amounts of non-depolarizing agent, which I'm going to tell you, the curare like drugs, I'm going to tell you in a bit. We're going to give that, and that is actually going to prevent this from happening. This concept is called as pre-curerization. Now, to really organize the information in your heads, I'm going to give some terminologies so that you will really understand the concept and also, organize the information in your head, and some more terminologies as well. Is that there are the concept of priming, pre-curerization, and self-teaming. So these are the three terms used in anesthesiology. Now, what you do is that for priming, you administer small, very minute dose of non-depolarizing drug, and then the inducing drug that you're giving in a large amount is also a non-depolarizing drug. That is then called as priming. But in pre-curerization, the small dose is of non-depolarizing drug. You see, they are the same. But the inducing agent is depolarizing or succinylcholine. Okay? And in self-teaming is basically kind of priming, but what you do is that you give a small dose of succinylcholine, and then the inducing drug is also succinylcholine. So I hope you get what pre-curerization is. Why are we doing pre-curerization? To prevent succinylcholine in order to produce fasciculations. We are preventing that. We are also preventing hyperkalemia and all the side effects of succinylcholine, but mostly for fasciculations. That's the main goal. Okay, that's that. Now we have non-depolarizing drugs. For the non-depolarizing drugs, they are actually all ACH antagonists. We have atracurium, mevacurium. Honestly, the most important one is tubocurium, curonium, and rocurium, rocurium or curonium. You can write it. And they are all ACH antagonists. They are called curar-like drugs because in the past they were used for hunting. In the arrowhead, in front of the arrowhead, the hunters would apply some of this drug, and they will then shoot the desired animal, and they will paralyze. The animal will paralyze, and they can have a nice hunting. Now, for depolarizing, we have an important concept is a reversal of blockade, because they are true antagonists and we need to reverse that as well, because of course nobody likes to be paralyzed. So we have Suga Maddox. Let me check the spelling. Yeah, Sugamatics. Or we can also give anticholine esterases. And the anticholine esterases, they are also going to reverse the how are they going to reverse? Because yeah, so where were we? I'm sorry. Okay, anticholine esterases, how we're going to help in non-depolarizing? Because they're going to increase ACH. Okay, when they increase ACH, of course the antagonist will go down. And if you are giving anticholine esterases and it is increasing ACH, you must also give anticholinergics. Okay, you need to give anticholinergics. For example, atropine. Of course, you don't need bradycardia with muscle relaxing activation. Sorry, we don't need bradycardia with muscle activation, so we need to give atropine for that. Okay, I think that's it for neuromuscular blockade. Now we will do the drugs used in Parkinson's. It's very easy. First, we need to know what is Parkinson's. So, Parkinson's is a disease in the nigrostriatal pathway, which is of course a dopaminergic pathway, and this here we have decreased dopamine. So what you do in Parkinson's is that you need to increase this dopamine. Now let's see how we are going to do dopamine. Now dopamine in itself cannot cross blood-brain barrier. So what we did is that we created another thing that is called as levodopa, and now this thing, it can cross the blood-brain barrier. Now let's follow through the journey of levodopa from the body into the blood, through the blood-brain barrier into the central nervous system. It goes through a lot, and we have to really, it's like a relay race. It's just, we have to just push levodopa through the blood-brain barrier, but we're gonna have hurdles and we have to crush all of those. So that is the basic Parkinson pharmacology. That's everything we need to know. So let's just do it. So levodopa, that needs to go through the blood-brain barrier. So here I'm gonna make a very simple blood-brain barrier. Blood-brain barrier. Let's just write BBB. Blood-brain barrier. Okay. But now this is general circulation. Above this is all general circulation. And what happens that there are two enzymes that would love to act on levodopa and just wants to transform it into other things. So the first enzyme is COMT. It wants levodopa to become 3-OMD. And another enzyme, DDC, dopa decarboxylase, that wants levodopa to convert into dopamine. Now this boy right here, that cannot cross blood-brain barrier, but what it would do definitely is cause dopaminergic actions in peripheral circulation, and we don't want that. We don't want peripheral effects of dopamine. Okay, we're gonna come back to that later on. Then once levodopa has entered the the CNS, it is then going to convert it into dopamine. Now we really do want it to become dopamine, because now we are in the central nervous system. Why don't we want it to happen? Now this dopamine is then going to get packaged. So sorry about that. Gonna get packaged into a vesicle, and then from this vesicle it is going to it is going to get released and attached to dopamine receptors, right? Also we have a dopamine reuptake right here. Reuptake receptor right here, and we also have a autoregulatory receptor right here. Now right here, this dopamine in central nervous system also converts into 3-MT by COMT. Again, the same old bad boys are also coming after dear old dopamine. And another thing is DOPAC, and it is by MAOB. Okay, MAOB or MAOB. So this dopamine, you see, is being pulled in so many different directions, but we just need dopamine here. We need dopamine in all its glory right here. How can we do that? we need to inhibit this, we need to inhibit this, and we definitely need to inhibit this and inhibit this. Okay, how do we do that? Let's just go on with it. COMT inhibitor, entacapone, tolcapone. DDC inhibitor, carbidopa. Then we have central COMT inhibitor, that's only tolcapone. Centrally, entacapone cannot cross blood-brain barrier. Okay, so that's not a central COMT inhibitor, that's a peripheral COMT inhibitor. Then what else can we do? We need selegiline and resegiline. Selegiline and resegiline to inhibit MAO. And there are two other things. We can give dopamine agonists. Those are pramipexole, ropinirole, and you can also give bromocriptine. So in younger patients, you will give pramipexole and ropinirole because they are non-ergot, and bromocriptine in older patients, they are ergot. Okay, and lastly, to inhibit reuptake, we have amantadine. Okay, and that is for Parkinson's drugs, and that is all. That is literally everything, and it's very simple. Two more things that I like to mention is that if there is drug-induced Parkinson's, you give benztropine and procyclidine. In younger patients, I told you pramipexole, ropinirole. In older, bromocriptine. But mostly in severe Parkinson's, you give levodopa, L-dopa, and daracopone. So there is a drug called as Stalevo. Stalevo has carbidopa, levodopa, and daracopone. And there is another drug called as Sinemet that has levodopa and carbidopa only. Okay, and then of course there is mostly a combination therapy in which you give levodopa and carbidopa with the selegiline or resegiline, and that's it for Parkinson's. In addition to Parkinson's, we can also look at Alzheimer's treatment, which is again very simple. There is a mnemonic called as Donna Riva, dances at the gala, and that is donepezil, rivastigmine, galantamine. These all are what? They are ACE inhibitors, acetylcholinesterase inhibitors. Okay, they are again first line treatments, and their possible side effects will be nausea, dizziness, and insomnia. Then there is another condition called as amyotrophic lateral sclerosis. You give riluzole, and the mnemonic is that because this is also called as Lou Gehrig's disease, so you can say that treat Lou Gehrig disease with riluzole. So Lulu is the same. Then for Huntington, you can give tetrabenazine, and tetrabenazine is basically, it inhibitors VMAT, that is a transporter that is going to decrease dopamine packaging. Okay, so it basically decreases dopamine, and you use it for Huntington's chorea. or you could also use it for tardive dyskinesia. And okay, that's done. Okay, now we do antipsychotics. For antipsychotics, we have two sub. How we basically do this is typical and atypical. And the major difference between these two is the mechanism of action. The mechanism of action for typical is that it only inhibits D2. It blocks D2 receptors only, but atypical blocks both D2 plus 5-HT2 serotonin receptors. Okay. Now, of course, when you talk about psychosis, it is said that psychosis is because of high dopamine, as in schizophrenia. So we need to decrease dopamine. But recent studies also shows with 5-H2 there is like some serotonin. I'm very sorry. There is also links with serotonin. So there is actually a chemical imbalance that cause psychosis. So that is why we're giving D2 antagonists and 5-HT2 antagonists. Only one thing is that epiprazole, it is a D2 partial agonist, so I'll just write it in highlighted form. Epiprazole is a partial D2 antagonist. Okay? Okay. Sorry. They just wanted to tell us how far we have come. Okay. Now, typical include 3. We have 3 for typical. 3 types. These are phenothiazines, thioxanthines, and butyrophenones. Let's see what they are actually, the names. Phenothiazines are flufenazine, and thionidazine, and chlorpromazine. Thioxanthines, then butyrophenones, they are haloperidol. I don't have an example for thioxanthines, and I don't want to think right now. Atypical are clozapine. Clozapine is used in treatment-resistant or suicidal thoughts. If a patient is having suicidal thoughts and if it is not responding to any other medicine, then we give clozapine. Then again, epiprazole, because again it's a partial antagonist, that's why it is an atypical. And olanzapine and many others. Okay, you just need 2 to 3 names. The thing that I can help you with a bit mnemonic that was written in first aid was that all typicals have azine at the end, azines at the end, while atypical has the apine, or they could be edones, right? So they are the suffixes for typical and atypical. Now, the clinical use is basically schizophrenia. It could also be for concomitant psychosis, such as in bipolar disorder. You can also give for Tourette's, Huntington's, and OCDs. Now we do the adverse effects, which are a lot. Okay, so the first we need to know is a anti-HAM, that is a mnemonic. So antihistaminic, anti-adrenergic, and anti-muscarinic. Antihistaminic, as in sedation, it will cause sedation. Antiadrenergic, it will cause orthostatic hypotension, And as antimuscarinic, you can have dry mouth and constipation and all those antimuscarinic effects. And then we have metabolic effects. It is gonna cause weight gain. It can cause hyperglycemia. Etc. with all, and dyslipidemia as well. And the highest risk of weight gain is with clozapine and olanzapine. Then we have endocrine effects. That is going to be hyperprolactinemia. Then hyperprolactinemia, of course, it causes galactorrhea, gynecomastia, all those things. And then for cardiac, we have QT prolongation. And for neurologic, we have neuroleptic malignant syndrome. I'm gonna talk about this in the psychiatry video if I make one. Right now, let's just move on. And ophthalmologic. Now here the chlorpromazine that causes corneal deposits, and that is only with chlorpromazine. I'm not writing it all. And then thyroidazine is also gonna cause retinal deposits, and that is thyroidazine. Okay. Now also, because if we are doing dopamine antagonism, we're gonna have EPS, that is extrapyramidal syndrome. And again, thank God we have a mnemonic for this as well. It is called as ADAPT. ADAPT is akathisia and acute dystonia, and P is for Parkinsonism, and we have T for tardive dyskinesia. How do you treat it? You treat it with procyclidine and benztropine. Okay. You can also give benzodiazepines. Let's write treatment as well. Benzodiazepines, and you are going to give Botox or botulinum injections. Botulinum toxin is more like serious name than Botox for some reason. And then phalbenazine and deutetrabenazine. Okay, that is a big name. You can remember how many as you want. Now there are two more things that you need to know, and then we're going to be done with antipsychotics. Is first that they are highly lipid soluble, so they're going to be stored in body for a long time. So that is why whenever we're giving injections of clozapine, and etc., we always give it once every 4 weeks or 2 weeks or 6 weeks, because they have great volume distribution and they get stored and redistribute very much. And typical antipsychotics, because they are solely made for increasing dopamine, and blocking dopamine, that is why we're going to have more EPS syndrome, neuroleptic malignant syndrome with them rather than with atypical. And then of course we're gonna have high potency antipsychotics and low potency antipsychotics. So high potency are haloperidol, high potency. So there is again mnemonic for that. The mnemonic is HAL tries spy to fly high. So HAL is haloperidol. T is trifluoperazine. F is for fluphenazine. Sorry, P है. P is for pimozide. F is for fluphenazine. And yeah, high is for high potency. And then for low potency, we have the mnemonic cheating thieves are low. You can check these from first aid. I'm literally copying it from there because I remember these like that. You are welcome to make your own if you don't like first aid mnemonics. So C for chlorpromazine. T is for thyroidazine. And lastly, L is for low. Okay, and that sums antipsychotics right here. Now let's talk a bit about lithium very briefly. So lithium, the mechanism is unknown, but it could be related to inhibition of phosphoinositol cascade, and it is given in bipolar disorder, especially manic phase, and it prevents its relapse, so in manic phase. And there is again the mnemonic which stands in its name. So L is for low thyroid, LT is for low thyroid, and H is for heart problem, Epstein anomaly. Low thyroid means hypothyroidism. It causes hypothyroidism, and then it causes nephrogenic diabetes insipidus, and then it causes unwanted movements with UM, that is tremors. So these are the adverse effects, and that is it for lithium. And next is bucyprone. Bucyprone is given for anxiety disorders, and it is a partial 5-HT receptor antagonist. Okay, now we do antidepressants. For antidepressant, first we need to know the mechanism of action of why depression happens. So there is an amine hypothesis for that. That amine hypothesis means that there is a decrease of norepinephrine and decrease of serotonin, and that causes depression. So we have right here a presynaptic noradrenergic terminal, a presynaptic serotonergic, and then a postsynaptic one. So in noradrenergic, we have a lot of NE, norepinephrine here, and in serotonergic, we have a lot of serotonin in this vesicle. What is going to happen is that this serotonin is going to get released. Norepinephrine and serotonin are going to get released into the terminal, and they are going to, this is an NE receptor and this is a 5-HT receptor, and they are going to activate their receptors. But because what we need to do right here is that we need to increase the serotonin and norepinephrine in the synaptic cleft. So what are we going to do with that? We are going to help that, make it happen. Okay, so right here I have made alpha 2 autoreceptor, and this is NE reuptake receptor, and this is a serotonin or 5-HT reuptake receptor. Okay, and of course this reuptake is going to reuptake norepinephrine and serotonin and give it to MAO enzyme, and that is gonna degrade it. So what we have to do right here is we have to remove, we don't have to do reuptake, we have to stop this reuptake, and we have to stop MAO. Okay, so how we're going to do that? Now let's see the drug classes. So first what we do is we use MAO inhibitor, that is going to stop that. We are going to do SNRIs. SNRIs are going to inhibit the reuptake, okay, of only norepinephrine. And TCAs, SNRIs and SSRIs, all these are going to inhibit the reuptake of 5-HT. And mirtazapine, only one is mirtazapine. Mirtazapine is going to inhibit alpha 2. And also here we have trazodone. These are trazodone and mirtazapine, they are actually atypical antidepressants. Okay, so now you know this. Let's look at the classes. So these are the typical classes, and then we're going to do the atypical drugs. First is the MAO inhibitors. The MAO inhibitors, the mnemonic for that is MAO takes pride in Shanghai. MAO takes pride in Shanghai. So what is for M? Let me decrease that a bit. What is M? M is for MAO-B inhibitors, okay. They are T4 phenylcypromine, phenelzine, I for isocarboxazid, and then S for selegiline, like that. Now they are non-selective MAO inhibition, and they're going to increase the levels of amine transmitters, but of course they're also going to increase dopamine as well. So what we're gonna do is they're gonna have let's do its adverse effects. I had a long day. Okay, adverse effects. The adverse effects are CNS stimulation, of course, a lot of CNS stimulation, and we also have the hypertensive crisis, because it is increasing everything. That's why we're having hypertension crisis. Hypertensive crisis. And then we are also gonna have that's it. Also, never use MAO inhibitors with tyramine. So I'm gonna explain important concept right here. So in the gut we have MAO, MAO or MO, whatever you want to call it. And when you eat cheese has tyramine in it. This tyramine is degraded by MAO. But when you have MAO inhibitors, this tyramine cannot be degraded. And this tyramine causes increased amounts of catecholamines. And that is going to get your patient into a hypertensive crisis. Okay, so you need to know this. Then we have tricyclic antidepressants. For tricyclic antidepressants, we have a mnemonic called as anti-DEP-C. Anti-DEP-C. So A is for amitriptyline. N is for nortriptyline. T is for trimipramine. The pronunciations are otherworldly, but we're gonna go through this, guys. We're gonna ace all of this. because we love this. That's why we are doing this. D is for doxepin. Then we have protriptyline. And lastly, we have clomipirine. But these are good shit, okay? And what does TCA do? TCA again inhibits both 5-HT and NE reuptake. So they are also reuptake inhibitors. And the clinical uses are major depressive disorders and peripheral neuropathy and all that, but majorly use it for major depressive disorder. If you have nocturnal enuresis, you're going to use imipramine, and in OCD we use clomipramine. Adverse effects are tricyclics. That's again another mnemonic, or you can remember it for 3 C's. So there are 3 C's: convulsions, coma, and cardiotoxicity. And it is also has alpha 1 blocking activities. So we're also gonna have postural hypotension and atropine like side effects. Okay. And the treatment to prevent cardiotoxicity is sodium bicarbonate. Next, we have SNRIs. So for SNRIs, they are serotonin, norepinephrine reuptake inhibitors. So they are for both. And they are venlafaxine, desvenlafaxine, duloxetine, and levomilnacipran. So I'm just going to write 2 or 3. We're going to have venlafaxine, and desvenlafaxine. So just remember these. These are the most important ones and most common ones. And duloxetine as well. Duloxetine. And again, they are 5-HT and NE reuptake inhibitors. Again, the uses we all know is depression, etc. And the only adverse effects with this is increased BP and stimulant effects. And that's it. And of course, you're going to have a bit of sedation with it. Then we have selective serotonin reuptake inhibitors. It's only for serotonin, not for norepinephrine. Okay, so you're not going to have all those cholinergic effects. So fluoxetine and fluvoxamine and sertraline and citalopram. Citalopram is the most common one, so you need to know this one: citalopram and sertraline. And adverse effects is fewer than TCAs, but you can have serotonin syndrome. So we're gonna do serotonin syndrome again in psychiatry, but right here, serotonin syndrome, you need to know that, and I'll do that in another video what that is. So that serotonin syndrome is the major side effect. And with that, you can also have dysfunction of sexuality. Okay, sexual dysfunction. You can have anorgasmia and decreased libido with increased serotonin. So you know that can also happen. Sexual dysfunction. And then we have 5-HT inhibitors. Now we look at some of the atypical antidepressants. First we have bupropion, and it inhibits NE and DA reuptake. Okay, so it's an inhibitor, and important for this is it is used for smoking cessation. And its toxicity is because it inhibits DA reuptake. That means that we have tachycardia, insomnia, etc., headache, seizures in patients with bulimia and anorexia. But there is decreased risk of side effects, sexual side effects, and weight gain. Okay, then we have next is mirtazapine, Mirtazapine is alpha 2 antagonist. And mirtazapine, it is going to increase the release of both norepinephrine and 5-HT. But it is more potent for 5-HT because it also directly activates 5-HT receptor antagonist and H1 antagonist as well. Antagonist. So usually its toxicity is sedation, which may be desirable in depressed patient if they have insomnia. So then you're gonna give mirtazapine, and mostly with mirtazapine you're gonna have increased appetite and weight gain. Okay, then we have trazodone. Trazodone is it primarily blocks 5-HT2 alpha adrenergic as well as H1 receptors. So it does all three. Then we have varenicline. Varenicline is ACH receptor antagonist, and it is also used for smoking cessation. Then we have vilazodone, which is 5-HT reuptake inhibitor. And then lastly we have vortioxetine, which is also 5-HT reuptake inhibitor as well as 5-HT agonist plus 5-HT3 receptor antagonist. So these are atypical. Now let's do opioids. And in opioids, first we need to talk about the 3 endogenous families and the receptors. So the endogenous families are endorphins and enkephalins and dynorphins. So these are endogenous, and of course opioids are exogenous. So these are exogenous, and receptors are mu receptors, kappa and delta. Mu receptors are mostly for analgesia, euphoria and meiosis and respiratory depression. Kappa is for dysphonia and delta is pro-convulsant. So opioids work on mu receptors. Now let's classify opioids. Opioids first are agonists, and then we have mixed agonists and antagonists, and finally antagonists. So for agonists we have natural, semi-synthetic and synthetic. In semi-synthetic we have heroin. In natural we have morphine and codeine. So codeine was used as cough syrup, and morphine comes from opium poppy. And synthetics are pethidine, tramadol, methadone and fentanyl. Remember, Michael Jackson died due to fentanyl overdose. Mixed agonist and antagonists are buprenorphine. So they are partial receptor agonist and partial antagonists. And then with antagonist we have naloxone, naltrexone, and methyl naltrexone. Okay, now we're gonna do some things about it in detail. Now for its brief mechanism of action, what it is going to do, it is going to it is an agonist at mu receptor, or also called as opioid receptor, and it is then it is going to cause closure of presynaptic calcium channels, and it is going to open potassium channels, and that is going to cause decrease in ACH release, and this ACH release as well as 5-HT, as well as glutamate, as well as substance P, and as well as norepinephrine. And that is the basic thing, that everything is decreased. That's why we use opioid analgesics when severe pain is there, especially refractory pain or severe pain. And its use also is in maintenance for opioid use disorder. In that we use methadone. So here is the concept of tolerance. So first, tolerance to the drug is going to generate, but not to meiosis and constipation. Okay, all the other effects like the pain, the serotonin release and ACH release, to all the other effects the patient will develop tolerance to those symptoms, but there will be no tolerance for meiosis and constipation, and that is slowly going to convert into addiction, right? And to treat this addiction, the opioid use disorder, we give methadone, but we can also give, for this reason, methadone and buprenorphine plus naloxone. So I'll write that as a buprenorphine and naloxone, right? Okay, then another important thing where it is used is fetal abstinence syndrome or neonatal abstinence syndrome. Neonatal abstinence syndrome, and it is called as NAS. It happens when the neonate or the fetus is in utero. It is exposed to a lot of drugs, and when that drugs are immediately withdrawn, that withdrawal is called as NAS. So to prevent, and that withdrawal is treated by methadone. Now for antagonist, one final word is that naloxone is short acting and naltrexone is long acting. So for acute opiate overdose, you give naltrexone. To reverse cardiovascular and respiratory depression, and naltrexone to prevent relapse, and yeah, that's it. But you do that after detoxification. That's it for this video. This is it for CNS Pharmacology. I will see you in the next video.